Hello, everyone. I'm Dr. Wanhong from West China Hospital, Sichuan University in Chengdu, and also I'm a member of Chinese Critical Ultrasound Study Group that we call CCUSG. Today we'll give you the lecture about critical ultrasonography and circulatory management in critically ill COVID-19 patient. Firstly, I will give the apologies because I missed the first two lectures because of the emergency rescue. In Wuhan, we have another COVID-19 patient. So I missed the first two lectures. Today we're focusing on the circulatory management of COVID-19. As we all know, COVID-19 has been outbreaks in all over the world, and there may be 30% or more patients were in a risk of bad outcome. So the hemodynamic therapy is very important in such severe patient. Firstly, let's review the basis of hemodynamics. As we all know, the blood returns to the heart as a preload around the vessels, be pumped out to the aorta as a cardiac output. With the help of the vascular tongue, they generate the blood pressure that drives the blood go forward to the organ as a tissue perfusion. If any damage happened to the hemodynamic, we got hemodynamic disorder. We divide the hemodynamic disorder into two types. The severe one is shock, which is characterized with deterioration of microcirculation and oxygen metabolism. And the second type is hemodynamic disorder without shock, including the vascular disorder, that is vasopressure and leakage, and the heart disorder that include the acute right heart dysfunction, the systolic and the diastolic dysfunction, and the cardiac disease or valve disease. The third is volume disturbance, include the fluid overload or fluid maldistribution, hyper or hypovolemia. This slide summarized the key points of the hemodynamic disorders to make you understand clearly. We can see there are many elements of hemodynamic disorders: the hypovolemia, fluid maldistribution, and the different types of heart function abnormalities, and the vascular insight, and the tissue perfusion deterioration. Firstly, we'll start with vascular insight. As we all know, the vessels keep the blood inlet without leakage. There are two important structures, that is endothelium and glycokinetics, that keeps the fluid in the vasculature. This pictures shows you the endothelium and glycokinetics and how the leakage. So if the diseases produce the inflammatory and the other in that the leakage happened and the fluid overload could be seen in the severe patient. We're focusing on the respiratory system. Why the lung is a key organ that the fluid maldistribution happened. There are three reasons, as we all know. Firstly is a big surface area of the alveoli. There are type 1 and type 2 epithelial cells. And the alveoli covered with plenty of capillary network. Also, they have endothelium and glycokinetics to keep the fluid in the vessel. And the third reason is there are huge blood flow in the lung because the flow of the whole body pass through the lung. So, knowing the reasons, we are not surprising about this research results that early risk factors and the role of food administration in developing acute respiratory distress syndrome in septic patients. We found the result that as the amount of fluid in the first 6 hours increased, the rate of ARDS increased either. Fortunately, we can see the result of the biopsy of the early stage COVID-19. The damage happened to the epithelial cell and the alveoli, and the vasculature and the endothelium is not damaged in the early stage. So the hypoxia is a key result of the early stage COVID-19 because of damage happened to the alveoli and the patient could not get enough oxygen. So there are acute severe respiratory failure. But as the disease progressed and as time goes by, the damage happened to the endothelium. So we can see in the later stage of COVID-19, the biopsy, we can see the damage happened and the vasculature broken and the endothelium and the glycokinetics were damaged. So the liquids happened. So we can make a summary about the mechanism of COVID-19 in the two stages. Firstly, the epithelial cell damaged in the very early stage, and the hypoxia happened. The patient got respiratory failure and may be very, very severe. And as time goes by and as the diseases progressed, the damage extend to the vasculature and the senior cells and the glycokinetics were damaged, and the vasculature were broken, and the leakage happened. That may be caused by the hypoxia itself, or the reaction of the hypoxia, or the inflammation, and may be caused by the disturbance of hemodynamics. So in the early stage, if we perform the non-ultrasound to the patient, because of the epithelial cell damage and the interstitium, and heavily damaged and increased water in the interstitial tissues of the lung, we found B lines, and we found ultrasonic non-interstitial syndrome, and we found subpleural small consolidation that corresponds with the biopsy in the early stage. And in the advanced stage, or we call the later stage, as the endothelial cells involved and the vasculature broken, the whole tissue of the lung were damaged. So, except for the hypoxia, the fluid linked out more and more, and the patient is more like ARDS. We see the sign of gravity gradient, and we see the water drops to the posterior part of the lung. The consolidation is commonly seen in commonly found in the non-ultrasound findings. So that's a different. So we see that in the early stage, the patient, the respiratory failure is caused by the virus itself, but in the later stage, the respiratory failure is by the virus and the leakage and the pathophysiological changes of ARDS. That's very important. So this is a chest CT and the non-ultrasound signs of the COVID-19 patient. We found in the later stage, as you see in the left picture, we see consolidation, we see many infiltrate and normal area of the lung, but in the right picture of the slide, the diffused interstitial exudation corresponds with CT. We found A lines and B lines and consolidation. These signs give you a clear picture what a patient happened to the pathophysiology of the lung. And what we learned from the work, there are signs that indicate the patient got more fluid leakage. If you see more consolidation, that means the worse endothelial injury. If you see more gravity gradient, that means worse endothelial injury. So the non-ultrasound and the other image method like chest CT and the chest X-ray is more valuable for us to recognize and realize the endothelin injury and realize the fluid linkage. But we should be cautious that the epicenter injury happened firstly and last the whole course. And the hypervolemia aggravates the leakage and accelerates more fluid maldistribution. So we could see such researches tell us the result that daily fluid balance is a key factor that to improve the outcome of ARDS patient. So also, if we face a COVID-19 patient, if we found the linkage happened, we should pay more attention to the daily fluid balance. Do not give the patient an extra fluid to increase, maybe that will increase the occurrence of ARDS. But we should be cautious that if we do the negative fluid balance, the patient is in the risk of shock, and we should keep enough volume to make the kidney and other organ got enough flow. That should be emphasized. So, as the first part, we talked about the result and the volume management. We should avoid the volume disturbance and do not give extra fluid to increase the positive balance of fluid, and be cautious to avoid the hypervolemia. And now we'll go to the second part. It's about the cardiac dysfunction of COVID-19. As we know, the cardiac dysfunction is common in the COVID-19 patient. There are different types. There are the compromised RV or the dysfunction of the left ventricle, including the systolic dysfunction or diastolic dysfunction. Firstly, the systolic dysfunction is we see in the COVID-19 patient. With the help of the echo, we can easily find if the patient got systolic dysfunction, and we can distinguish the types of the dysfunction. This video shows you there's a diffused depression of the left ventricle, and this picture and this video show you that there's a regional hypokinetics of the left ventricle. This systolic dysfunction found in the COVID-19 patient may be caused by many reasons. And the stress cardiomyopathy is also could be seen. The venous attack, we do not have enough evidence, but it may be happen. And this severe hypoxia may be the main cause of the systolic dysfunction. And the cytokine storm will be another cause of the systolic dysfunction. And in the later case, in later stage of the treatment, as a patient got sepsis or the septic cardiomyopathy, maybe the cause of the systolic dysfunction. We should be cautioned that the pre-existing chronic systolic dysfunction is also found in the COVID-19 patient. And as the disease progressed, another problem we have to face is the ACP. We all know the damage it happened to the lung, and the damage itself can cause the vasculature broken, and other factors such as hypoxia, hypocarbia, and edema. All the settings of the ventilator could increase the time of the pulmonary vasculature that caused the pulmonary hypertension. And the pulmonary hypertension works as an afterload of the right ventricle, which makes the depression of the right ventricle. Unfortunately, in the late stage biopsy of COVID-19 patients, we found a heavy damage in the lung, including the vasculature and the other tissues of the lung. Also, we found other pathophysiology changes that may increase the pressure of the pulmonary vasculature. And the increased pulmonary hypertension damaged the right heart to cause the ACP. With the help of echo, we can easily diagnose the ACP and to evaluate the extent of the ACP and to evaluate the consequence of ACP. We see an enlarged right ventricle and a fractured septum of the heart. Not only the primary hypertension, but also other factors, including the fluid administration or the other factors may also contribute to increase the depression of the right ventricle and accelerate the degree of the dysfunction of the right heart. One of the key consequences are high CVP that caused by ACP. The higher CVP value can decrease the flow of the kidney and cause the acute kidney injury. As we see from this video, we can see a lower CVP. Under a lower CVP, the flow of the kidney is good, and under the same mean artery pressure, our increased CVP caused the flow of the kidney decrease. So we should pay more attention to adjust the CVP, to lower the CVP, and we should make sure our lower CVP do not lead to the circulation collapse. The second important consequence of HCP is the depression to the left ventricle. We all know enlarged right ventricle can press the left heart, and the left heart could be depressed, and the dysfunction of left heart happened. So we should pay more attention. So monitoring and management of ACPs are very important. Firstly, we should do dynamic echo monitoring to find the onset of the ACP as early as possible. And we should evaluate the severity of ACP and lead us to do careful treatment. The management of ACP, including such as the setting of the ventilator to improve the hypoxia, and to do the fluid removing under fluid overload condition or others. And the key treatment is the prone positioning under our ARDS patient. We all know, we all very familiar with the prone position treatment. Other research told us if we do prone position to our center patient, and the mismatch of the air and the flow of the lung were improved, and the afterload of the right ventricle decreased, and we can see an improvement of the right ventricle. So here is a summary of the strategy for ARDS mimics. Also, the strategy is very useful for us to treat a COVID-19 patient in intensive care unit. We summarize it as 3P CVP, that is protection of the circulation, protective ventilation, or prone positioning. The factors were listed in this slide, and we should pay more attention and do it better. Then we go to diastolic dysfunction. The left aorta is most important, as it's a stop of pulmonary flow, and if our high pressure of left aorta can aggravate the lung leakage and worsen the pulmonary hypertension. So we should pay more attention to the diastolic dysfunction. How the diastolic dysfunction happened, we do not have enough evidence about the virus attack to the heart. Although we found the virus in the mechanical muscles in the biopsy of the patient, but we should pay more attention to the patient with pre-existing chronic diastolic dysfunction, especially in the elderly patient. And we should control the increased heart rate and do not give fluid to cause to result in a fluid overload that may cause the diastolic dysfunction be worsened. Also, our decreased systolic function may increase the severity of this diastolic dysfunction. So we should improve the systolic dysfunction to improve the diastolic dysfunction. Now we'll go to another hemodynamic disorder, that is tissue perfusion deterioration. Shock. Shock is a severe hemodynamic disorder, and it's happened to the critically ill patient and is commonly seen in COVID-19 patients in the later stage in intensive care unit. And shock is a hemodynamic syndrome caused by clinical disease, and it could be worsening independent of origin disease. But fortunately, there's a rare shock in early stage in COVID-19. But we see it's usually the blood pressure drops after the patient is intubated and be given deep sedation. So we should be cautious before the intubation and before we order the sedation. But if the patient progressed to the later stage and being admitted to intensive care unit, we found shock is usually seen in some condition. And there are many types of shock we're seeing. And septic shock is most commonly seen in intensive care units. When we facing a patient shock, we'll talk about how we treat the shock patient. Dr. Vincent and other colleagues gave us 4 phases in the treatment of shock. They divide the course of shock into the salvage phase, optimization phase, and stabilization phase, and the de-escalation phase. We'll talk about the optimization phase, how we treat the patient and optimize the perfusion. The 5P theory is valuable guidance for the internists to optimize the perfusion and to give the high quality treatment to shock patient. We'll introduce the 5P theory soon. At first, we'll review the basics of hemodynamic. Firstly, tissue perfusion is a key point that we should pay more attention. So the first P will start from perfusion. You should test the lactate and do other assessment of the tissue perfusion to realize the patient be worsening in the tissue perfusion. Then we go to the second P is pressure. The pressure is a key point that drive enough flow to the tissue. So the pressure is the first treatment we should perform. We use the vasoactive drugs to increase the pressure and to fulfill the perfusion of the tissue. And as we all very familiar with the drugs, we do not spend much time at this moment. But you should be cautious that our high pressure do not often mean that the microcirculation is enough. We could see in some cases the lactate is high in under very high pressure. That means the BP and the microcirculation is uncoupling. So under these conditions, we should think about if the cardiac output is enough in such a condition. So when we face a patient with good blood pressure and bad tissue perfusion, the cardiac output is need to be assessed carefully, and the measures to increase the cardiac output is very important and should be put on the table. We have many inotropic agents listed in this table, and we do not spend time to explain the drugs, as you all know the drugs and do it well. The fluid responsiveness is always a key topic when we talk about increasing the cardiac output. We use many tools and many measures to evaluate, to assess the fluid responsiveness. As we all know, if the patient have the if the patient needs fluid administration, the fluid resuscitation should be performed immediately, as we all know. But if we doing the fluid resuscitation, we should be cautious that the fluid administration could lead the hypervolemia and cause the fluid overload, and the fluid overload could lead the increase of the CVP value and worsen the pulmonary edema and increase the PAWP. So the fourth P is the two index that is including the CVP and the PAWP that we should pay more attention when we do the fluid resuscitation or management of the fluid. And at this time, the critical care ultrasound is very valuable. We use critical care ultrasound to to monitoring the B lines of the lung to know the severity of the lung edema and to know the changes of the lung, the changes of the degree of the lung edema, and to assess the diameter and the shape of the IVC, to pause the fluid resuscitation and do more to improve the pressure of the left aorta and the right heart. Then to recheck if the patient needs more fluid and how we administrate the fluid. Also, the CVP is a very useful marker that we assess the risk of the abdominal organ, that if the organ is under hyperperfusion or under hypoperfusion, and we will know the risk of the injury of the abdominal organ. At this time, we may talk again that the critical care ultrasound is very, very important. Under the reaction of the hypoxia and the inflammation, or under the stress of the COVID-19 patient, the heart is often being hypercanic. So the hyperperfusion of the lung may increase the lung edema, and the stress of the whole body can largely increase the oxygen consumption. So we should calm down the body and decrease the stress. And the pulse is a very useful marker for us to assess the heart and the stress. So we should control the pulse and to calm down the heart, calm down the body, to decrease the stress. This picture listed the factors that increase the oxygen consumption that we may pay more attention. So in summary, the 5P theory is very valuable for us to optimize the patient under shock and to get the high quality treatment to cure the patient under shock. And we'll introduce the PACE class workflow that including the pathophysiological treatment and etiology treatment of shock, and cover the whole course of shock, including the salvage, the optimization phase, and the de-escalation phase of shock. We do not spend much time to introduce this, as you can get more information from the paper. We'll emphasize that the base of the workflow is the examination of the critical care ultrasound. So we'll go to the examination of critical care ultrasound. As we all know, the critical care ultrasound is not only a ultrasound to give you the image of the organ, but also give you more information about the function and the pathophysiology of the organ and the tissue. So this is a modified CCUE protocol. We recommend to you to do the hemodynamic examination that include the 5 views of the heart and the 4 points of the lung each. The 5 views include the parasternal long axis and short axis and apical fold chamber and subcostal fold chamber and the long axis of the IVC. And the 4 points we do to the each lung include the upper blue point and the M point and the plus point and so on. We get the views of such point or such part to gather more information about the structure, the function, the flow, and the science of the non-ultrasound to assess the air and the water match of the lung, and then we assess the hemodynamic according the approach that we recommend. We call the approach standard hemodynamic assessment approach. There are 6 steps. Firstly is about the premorbid heart function, and we should assess the general changes. And second, we should assess IVC and vital status. And third, we should assess right ventricle, the function and the structure. And fourth, we will assess the left ventricle to know the diastolic function and the systolic function. And the fifth, we will to evaluate the ultrasound of the patient. And the sixth, we should evaluate the tissue perfusion and the non-edema. This is a 6-step approach. With a 6-step approach, we can know more about the hemodynamic changes. Then we can give acute treatment to the patient. Now we'll talk about the first step to know the heart function and obvious abnormality of the patient. We do eyeballing to the heart to do the early detection of premorbid heart disease. We will evaluate the chamber, the wall of the heart, and the valve of the heart. We should know that the right ventricle is the only ventricle that can enlarge acutely. And if any enlargement of the other ventricle happened, we should deduce that the patient is under a chronic condition, chronic disease of the heart. Also, the wall of the ventricle is very important. If the wall is thickened, the chronic pressure overload is found in such patient. And the change of the shape of the chamber may be very useful for us to assess the patient's basic chronic disease. As we see in these videos, there's an enlarged left ventricle and enlarged left aorta, and we see the thickening left ventricle wall, and we see the enlargement of the left aorta, and we see the thickening of the right ventricular wall. This may all indicate that the patient is under chronic heart disease, and if such patient got COVID-19, you can know the risk before the patient admit to before the patient become severe. In such a patient, you can imagine that the patient is under a high risk of pulmonary edema because the enlargement of the left aorta, right? And also the thickening of the left ventricular wall may indicate that the patient is getting a diastolic dysfunction, that maybe the left aortic pressure is high and the patient is in a high risk of lung edema. And the next step, we go to IVC assessment. We will assess the diameter of IVC and at the end of expiration, and we see the respiratory IVC variation to assess the fluid responsiveness. And we see in a collapsed IVC usually indicates that the patient is under hypovolemia, and if the patient got shock, then the fluid resuscitation may be administered. And a small hypercanic left heart or a small hypercanic heart may be another sign to confirm that the patient got hypovolemia, and to get more fluid under the condition that the shock happened. And the dilated IVC or enlarged fixed IVC often means that the patient is under fluid overload of the right heart or fluid overload of the whole heart. So when we face a fixed IVC, we should go to the right heart assessment to know if a patient is fluid overload of the right heart or fluid overload of the whole heart. In a patient with a medium state of IVC, we should assess the respiratory variation of IVC to judge the patient if the patient is fluid responsiveness. Also, we can use other dynamic hemodynamic parameters related to the blood flow to help us to do the judgment of fluid responsiveness. This table, this picture listed the method that we do to do the volume responsiveness assessment. We can pay attention to remember the such methods. Then the third step, we go to cardiac assessment. We assess the heart from the right to the left, just as the blood flows. So the right heart is firstly assessed when we're doing the cardiac assessment, and then left diastolic dysfunction, and then left systolic dysfunction is assessed when we face a patient. So when we assess the right ventricle, there's three factors we should remember. The first is the size of the right ventricle. The size of the right ventricle is very, very important because of the feature of the right ventricle. If the pulmonary hypertension occurs, the right ventricle could be enlarged, cause the thin wall thickness. So we assess the size to know if the right ventricle is dysfunction, and we assess the septum to confirm that the right ventricle is dysfunction, and to know the extent of the dysfunction, to know the severity of the dysfunction. If the D sign were found, we'll know that the dysfunction is very, very severe. And we will assess the motion of the free wall of the right ventricle as a third step to assess the right ventricle. And there are two additional factors we should assess is the size of right atrium and the thickness of right ventricle wall. That may be helpful for us to judge if the patient is acute or chronic dysfunction of right ventricle. Then we go to the left ventricle function assessment. We usually use eyeballing to assess the left ventricle. We assess the structure, assess the function, and we assess the flow of the left ventricle to get more information about the left ventricle. The diastolic the diastolic dysfunction is firstly assessed, and the left atrium is a key part to assess if the patient got bad diastolic dysfunction. If enlarged left aorta is found, that means the patient is got a very bad diastolic dysfunction, and the patient may be in a high risk of lung edema. If the patient has got COVID-19, we'll pay more attention to control the heart rate and pay more attention to manage the fluid and avoid the fluid overload. Then we will talk about the estimation of the left ventricle systolic function. We also use eyeballing to estimate the left ventricle systolic function. We'll assess the degree of the dysfunction of the left ventricle, and will assess the type of the dysfunction of the left ventricle to know if the patient is diffused, depressed, or the patient got regional hypocanic movement of the left wall that may caused by the stress or the coronary artery disease. These pictures show you different kinds of stress cardiomyopathy. When we performing the critical care ultrasound, we should pay more attention to realize the different kinds of stress cardiomyopathy. And the fifth step will assess the afterload of the patient. If the patient is under the condition that he got a normal anemia and the normal heart function, then we can conclude that the patient is, if the patient is under shock, we can conclude that the patient is under decreased arterial tone, and we call the patient is decreased systemic resistance. And the third step will do the assessment of the lung and the kidney, as the two organs is a marker that to assess the risk of the or the negative consequence of the hemodynamic treatment. You know, the diffuse B lines found in the lung ultrasound may give you the information that you have to distinguish the patient is getting a lung edema or other disease just like COVID-19. And the flow of the kidney is a marker that to tell us how the organ perfusion looks like. And this slide is a summarize of the hemodynamic assessment approach. We'll review the sixth step of the standard hemodynamic assessment approach we recommend. Firstly, we'll do the assessment of the chronic condition of the heart to know if there's an acute, obviously enlarged right ventricle that caused by the acute factors or chronic disease, and where to assist the wall seeking or the chamber changing of the heart to know if the patient got other chronic heart disease. The second step, we should assess the violence status by assessing the IVC. We should assess if the patient got acute obviously collapse or obviously dilated and fixed IVC, or in the medium state, we use other method to assess the fluid responsiveness. And the third step will assess the right ventricle from the size or the septum and the motion of the free wall of the right ventricle. And the fourth step will assess the left diastolic dysfunction of the left ventricle to see if there's an enlarged left aorta, or if how the cardiac systolic dysfunction, or if the patient got myocardial hypertrophy, and will assess the degree of the dysfunction of the left ventricle by eyeballing to distinguish the different degree of dysfunction. And we'll assess if the patient is diffuse depression of the systolic function, or if the patient got regional or motion abnormal. That means different kinds of disease that cause such a dysfunction. And the fifth step will assess the vasotension and the volume, the RV function, and the LV function should be taken consideration to assess the vasotension of the patient. And the sixth step, we should do the assessment of the lung and also the assessment of the kidney to assess if there's signs of ANMs, BNMs, or consolidation, to judge the pathophysiology changes of the lung if the patient got lung edema or others. And we should assess the flows of kidney as a marker that how the other organs get perfused, and if another stage of optimization should be studied. That's the summary of the critical ultrasound examining protocol and the approach that we do to do the standard hemodynamic assessment that may be very helpful for us to manage the circulation disorder of the patient, especially the patient of COVID-19. That's very important. So at the end of this lecture, we should summarize in the key point as such as the first, The hemodynamic disorder is common, especially in the later stage in COVID-19, and the management of hemodynamic disorder is equally important. Shock is rare in the early stage, but is commonly seen in the later stage that need intensive care. And the 5P theory and the flow-guided therapy are valuable in the management of circulation disorder. And the critical care ultrasound is valuable in the circulation management in critically ill in COVID-19 patients. I know there's so much information I do not mention and you are very interested in, and we'll talk about further in other classes or lectures, and we'll summarize our experience and to publish them in papers to share our experience to you. Then we can care more people to win the battle of the COVID-19. Thank you very much.